Hello, friends. Dave Bjork here, lung cancer survivor, patient advocate, and yes, I'm the research evangelist. And welcome to the Research Evangelist podcast, coming to you as always from just outside of Boston. You know, the Greek meaning of evangelist is bringing the good news, and I like to think that I'm bringing the good news in cancer research and care by interviewing people in life sciences that are doing amazing work. I call them brilliant but not famous, and well, the not famous part is ironic because they are all well known and respected in their field by their peers and the communities that they serve. But my next door neighbor would probably not recognize their name. But they really are brilliant and committed to their work. I love meeting these amazing people, sharing a little bit about them, what they're passionate about, the work they're doing. And I also believe in serendipity. So I hope some positive things come from sharing these stories with you and to the universe. So today I'm super excited to have on my show Dr. Eric Singhi. Dr. Singhi is assistant professor at the Department of General Oncology, Division of Cancer Medicine at the University of Texas MD Anderson Cancer Center in Houston, Texas. He's also assistant professor, Department of Thoracic, Head and Neck Medical Oncology at MD Anderson. Eric received his medical degree from Medical University of South Carolina. He did his clinical residency at Vanderbilt and his fellowship at MD Anderson. Eric, it's great to see you. Welcome to the program.
Thanks, Dave. Thanks so much for having me. I really appreciate your time and obviously the whole mission of your podcast.
Awesome. It's great to see you, man. So we met recently at the End Lung Cancer Now gathering in Indianapolis. And I guess I didn't realize that our mutual friend, Misty Shields, I didn't realize until you told me that you had actually trained with her at Vanderbilt, which is awesome.
Yeah.
And of course, you had on your Duke jersey, and I had on my Tom Brady, very unpopular in Indiana, having my Tom Brady jersey on. Why don't you start by telling us about the younger Eric Singhi?
Yeah, of course. So you did a very nice introduction. Thank you for that. That was very kind. So I actually grew up in the Carolinas. I was born in Canton, Ohio, which is known for the Pro Football Hall of Fame.
Yeah.
And my maternal grandfather, and we'll talk more about him, I'm sure, during this episode, actually practiced in Canton, Ohio as a family medicine physician. And so I was born there, very briefly lived there, and then moved to the Carolinas very early on.
Mm-hmm.
And grew up in South Carolina, right near Charlotte, North Carolina, actually, for most of my life. And then went on to go to Duke University for undergrad. Big Blue Devils fan. I know that's a polarizing team, if you will, but they're near and dear to my heart. I used to tent out for the games. Love being a Cameron crazy and getting to watch the games there. So
I can imagine. You know what's really funny, Eric, is I have a friend of mine who played basketball at Penn, where I went to school, and Penn in 1980 was in the Final Four. I mean, this guy. My friend's a lot older than me, but he explained to me that he had offers from Duke and from Penn, and he chose Penn because Penn was a better basketball team
wow,
in the
okay.
late '70s and early '80s. Isn't that crazy?
Yeah. Wow, that is crazy, huh?
They lost. The Penn lost to Michigan State in the Final Four
Yeah, wow.
with Magic Johnson. Anyway,
Wow.
um,
Oh, what a connection.
so you do have a lot of fame in the Carolinas, and you mentioned your grandfather, and I want you to tell us about the inspiration that you got from your grandparents, both your grandparents actually, but your grandfather, who was a doctor. Tell us about how that kind of played out.
Yeah, absolutely. So my maternal grandfather was actually recruited from India during the time where there was a pretty high national shortage of primary care physicians here in the United States, but was recruited from India to practice family medicine here. And he took his job very seriously and was incredibly committed to providing service for the patients in his community, from pediatric care to geriatric care, and would take home calls during that time. And I was incredibly close with him growing up. And so I got to see that provider perspective of what an impact a longitudinal relationship with your patients can have, not only to the patient, but to their families and to their loved ones. And it was such a humbling sort of relationship to see and to hear the stories he would share with me. And it really inspired me to want to get into medicine and to provide very similar care to my future patients.
And it's really that compassion that you feel it as a patient. I mean, I've been a patient. We've all been patients, but you can actually really feel it when somebody who really cares. He takes phone calls, or here's my cell phone number if you need to call me, that kind of thing. It's really pretty amazing, when you think about that, right?
Yeah, no, I 100% agree. I think all of us want to practice evidence-based care, especially in cancer when there's such rapid advancements, especially in the space of lung cancer, right? But that component of practicing compassionate care, I think, is equally important. And so, really feeling not only the science, but also that art of oncology is so fundamental to the care that you provide to your patients.
Yeah. And so you ended up at Vanderbilt, and so I don't know if you remember if you told me, but did you work with Christine Lovely when you were
I
at
did.
Vanderbilt? And what about was Lyra Horn there? Do you remember
She
Lyra?
was. Both of them were my mentors in thoracic oncology, and talk about just a dynamic duo of these females in oncology leading the way in thoracic oncology and incredibly kind and just so brilliant and were willing to sort of take me under their wing very early on as a bright and eager intern interested in wanting to become an oncologist myself. So I cannot say enough amazing things about Dr. Lovely and Dr. Horn.
They both have been on well, I haven't had Christine on my show, but I just saw her at the longevity
Uh,
gala in New York City recently, and we were talking. But I have Leora on my show, and her story is amazing. The whole coming from Canada to Tennessee, and the whole story. But now she's at AstraZeneca, and she's just killing it. She's doing great work. So,
she really is. I actually just got to catch up with her last ASCO.
oh, did
We
you? Okay.
in the hallways of ASCO, which I feel like is a very common phenomenon, just running into people, catching up with people. And then we spent more time actually in the airport when we were waiting for our flights, just catching up, reflecting on our time at Vanderbilt together, her transition from academics to industry, and just continues to give me excellent career advice and continues to be a good mentor, friend, sponsor. So I really appreciate that.
No, and when people make the transition to industry, I can totally appreciate that. I think we talked about Biljana,
Mhm.
who I just recently had on my show, and her transition from being a medical doctor to industry because he felt like she could have great impact. But you're having great impact at MD Anderson. I know we talked about about your practice, but after Vanderbilt, how did you end up? How did you select, or how did you end up in Texas as a Ohio Carolina guy?
Yeah, I feel like I've continued to sort of do this movement, if you will, every time I transitioned from different levels of training. And so I changed sort of where I was doing my training and education from undergrad, and then went to med school somewhere else, and then went for residency somewhere else. And then I just felt like I needed to constantly keep moving to learn more about not only how one institution works, but how several institutions approach patient care. And so that was really important to me, one, to just obtain all of these perspectives during my training. And then MD Anderson was just an amazing opportunity. I was so fortunate to be accepted to their fellowship program. I wanted to get a perspective of what a individualized tertiary cancer center looked like, because I'd always done my training in centers that were very well accomplished and sort of well respected with regards to academics, but they really focused on providing care for all different types of patients, not just patients with cancer. And so when I wanted to focus in on cancer and really get that expert level of care, the really high number of clinical trials, that's why I said I want to go to MD Anderson and to be able to have that subspecialization, if you will.
Yeah, and by the way, how did you end up choosing thoracic oncology, lung cancer as your primary focus?
Yeah. So I like to say that, or the way I kind of frame this is that cancer is a very sort of profound experience. And I feel like a lot of people have this universal experience with cancer, whether it's from knowing a family member, a friend, a colleague, but it's also a really deeply personal experience, right? So everyone experiences cancer in their own way. And I don't think anyone can have the exact same experience as another person, another patient, another loved one. So I had an experience like that too, as well, growing up very young, particularly with lung cancer with a family member I was very close with. And I got to see the emotional and physical toll that lung cancer has specifically on the patient and on the family. And that really affected me. And so that was always sort of deeply seated in my mind. And then fast forward to really seeing my maternal grandfather take care of his patients and being inspired to get into medicine, I wanted to combine both of those perspectives. So that's sort of how the lung cancer story started with me very early on. And then fast forward to medical school, learning about all the different advancements that we're having for our patients, targeted therapy, immunotherapy, not just traditional chemotherapy, really trying to personalize the care for our patients with cancer got me so excited. And then I got to Vanderbilt, identified some incredible mentors, which we've already talked about. And they really took me under their wing and they really helped me focus in on thoracic oncology. And ever since then, that's really been the lens that I focused on with regards to cancer care.
Yeah, and what's interesting is I was diagnosed, a long time ago, and there weren't a lot of treatments. And a lot of the people I've had on my podcast are actually like maybe 10 or 12 years ahead of you in their
Uh,
career journey. So when they chose lung cancer, people were kind of scratching their head like, why would you want to, in 2000 or 2002, like, why would you want to enter the field of lung cancer? You know what I mean? And now
yeah.
you've seen this rapid advancement in your career, right?
Yep. Yep. And now the question is, why not get into lung cancer, right? Why not have the opportunity to personalize, treatments for patients and really make a difference in sort of impacting and transforming the care we're delivering. So, yeah, it's a really interesting perspective. I always appreciate the historical perspective of cancer care, particularly thoracic oncology, when we go through the ISLAC meetings and get to see that timeline, if you will, of how quickly and sort of what a transformation we've been able to deliver for our patients with lung cancer.
Yeah, I mean, we still have a lot of work to do, but we've made so much progress that it has been transformational, with and it's because research matters.
Yep.
I mean, that's literally why I'm the research evangelist because I believe I think about like Jim Allison, another Texas guy, like like when he was promoting immunotherapy 20 years ago or however long ago it was, they probably thought he was crazy.
Yep.
And then he wins the Nobel Prize,
Yeah.
right? And so we kind of stand, I always feel like you guys stand on the shoulders of those who came before you.
Mhm.
And that's what I really love about medicine. My wife's a nurse, my son's a nurse practitioner. I love the healthcare field. But I feel like, those mentors that you talked about, like Christine Lovely and Leora Horn, were there others, or are there others at MD Anderson that have been mentors to you? And then, you're a young guy, but I'm sure that you're also now starting to think about how you can be a mentor to the people coming behind you.
Yeah, no, I think that's a great question. Mentorship and sponsorship in the medical field are everything, absolutely everything. Um, I am really trying hard myself as an early career faculty to give back, right, to those that are up and coming and rising stars, if you will, in oncology. So at MD Anderson, I help to co-direct our thoracic medical oncology rotation for the fellows. So I work with almost all of the fellows and trainees as they progress through their hematology oncology fellowship, and it's incredibly valuable to me. It's fun to teach them. It's exciting to talk about research projects to really understand what motivates them, what gets them excited about the field of oncology. And then at the same time, we really talk a lot about making sure that they practice compassionate care. So we really focus a lot on taking care of the mind, body, and soul of our patients that we see in clinic. And so we spend a lot of time of that, and they know I mention that all the time to my patients. So hopefully, I'm helping them with not only sort of their research, their career opportunities, but also just helping to become incredible clinicians. So I can't say enough about wanting to give back.
Well, I think Leora was the person who first told me about the difference between mentorship and sponsorship,
Yeah.
which I had never even occurred to me. But that this idea of like leaving the ladder down or like helping promote people into positions of that they deserve,
Mhm.
and it's not just the mentorship training, it's like actually taking the initiative to sponsor somebody to try to promote their career, right?
Yeah, absolutely. So I think mentorship is where you're more hands-on, you're directly helping to sort of shape the career of an up-and-coming physician, whether it's talking about research projects, collaborating on research projects, really pushing forward science. And then sponsorship doesn't necessarily have to be that. Sponsorship is shining a light on what maybe the mentee's already doing, right? Whatever the trainee's doing already, just promoting them to have opportunities for visibility, to be seen, and to really make an impact on the community that they're trying to reach. And I have been so fortunate to have incredible mentors and sponsors. And so one of the sponsors, and he's also a mentor to me, is Jack West.
Mm.
Jack West is just an incredible human being. I've worked a lot with his Cancer Grace organization, which is really focused on patient education. Was one of sort of the patient education ambassadors when I was a fellow and trainee during my fellowship training at MD Anderson. And he and I have a lot of mutual interest in patient education and advancing that forward. And I was very fortunate to have him mentor me on some aspects, collaborate on some research projects, but also sponsor me to go and present at conferences or being able to be faculty at certain conferences. So that was really nice. And I appreciate that so much.
That's awesome. That's so great. Well, that's a good segue too, because I was going to ask you about have you tell us about your patient education research that you care so much about. And you told me, and you just mentioned it, but you told me when we talked last time that it was to you, it was the heart and soul of your research efforts. So
Yeah.
can you talk to me about that?
Absolutely. So, what I think is just as important as advancing our therapeutic landscape for patients with lung cancer is making sure that patients and their families understand why one drug might be better for them than another drug, understanding really the intricacies of their disease and what their treatment plan is and what their goals are. I sometimes feel like we don't do a great job as a community of sort of medical providers to make sure that our patients are truly informed, truly empowered about the care that they're receiving. And I've seen it. I've seen it from the caregiver perspective, the family member perspective, and then I've seen it on the other side as a provider, right? That there's really this gap in communication and education. And that's always something I've thought about. And so I was so fortunate to be connected with the Cancer Grace organization when I was a fellow and really given an opportunity to connect with key opinion leaders in thoracic oncology and even outside of thoracic oncology, breast and you name it, and had dedicated sessions to really talk with them, brainstorm ideas on how we can advance patient education and move that forward. And through that, I actually got to get connected with some really amazing patient advocates in the lung cancer community. So Jill Feldman, she's become not only a collaborator, but a dear, dear friend of mine. And I appreciate her perspective. Every time I hear her talk, I feel like I learned something new,
Yeah.
I think I told you this too when we were at the End Lung Cancer Now event. But
Yep.
I really, really appreciate that perspective. And so we've sat down, we've talked about projects, and so we've done different surveys and studies trying to assess, for example, the availability and demand for patient-friendly resources in lung cancer. So currently, what's out there to help patients really understand their diagnosis, their treatment plan, their treatment goals, and the data behind why a treatment plan was selected for them, and then how we can sort of advance that gap that's there currently. And I was able to present some of our work, for example, at World Lung, which was a really nice opportunity, and hoping to really continue to build on that to lead prospective non-therapeutic trials to really identify gaps in patient education. And so that's currently something I'm working on as well.
Well, it's interesting. I hear a lot about shared decision making, and I'm not sure if I love the phrase. I get what it means, but it's like when you talk about treatment plans, it's like there's so many variables because it's like you could do this one or you could do this one. Like how do you choose? Like it's but then you talk about you're seeing a lot of patients, caregivers who want to empower themselves, and a lot of people that you see might be younger
Mhm.
and they might have driver mutations. And so, how do you kind of work with them to make sense of it all or to help them get empowered?
Yeah, that's a great question. So first, I'll touch on sort of seeing younger patients. That's really become my clinical and research focus at MD Anderson, and so probably the majority of the patients I'm seeing now are 50 and younger. So this young onset lung cancer. We're continuing to raise awareness about this subgroup patient population that not a lot of America and even outside of America are really paying attention to or that are aware of. So just as sort of a statistic, a lot of these patients do not have a smoking history. They have no vaping history, right? And there's so much stigma surrounded around a diagnosis of lung cancer where a lot of people think you have to smoke to get lung cancer. Most of these patients that are young do not have a really heavy smoking history or any smoking history at all. And so a statistic in the States right now is that 20% of patients being diagnosed with lung cancer have never touched a cigarette and are being diagnosed, right? So that's a really startling statistic. So one of the things I'm really committed to is raising awareness and working with advocacy groups that are dedicated to young onset lung cancer. So there's the Young Lung Cancer Initiative, the YLC,
Hmm.
and doing incredible work to really raise awareness and hopefully prevent delayed diagnoses that we're seeing all too often, unfortunately, for these young patients. And so working closely with them, working very closely with other biomarker patient advocacy groups like EGFR resistors, ALK Positive Inc. It's incredible to be able to connect with the communities that are out there and making sure that we can help empower patients throughout their cancer care journey.
Yeah. Have you done any work with ALSI,
Oh,
American
without,
Lung
yes, yes,
Cancer Screening?
yes.
Dr. Yang, Jeffrey Yang.
Yes, absolutely. So I know that they have national chapters and then they have local
Yeah,
chapters, and they're doing incredible work. So the one
they're a force.
they are a force, and they are really. I love how they are inspiring and motivating the next generation.
Yeah.
So the local one that we have here in Houston is the Rice chapter, the Rice
Okay.
chapter, and I cannot say enough amazing things about them. I was so inspired to be invited to speak to a bunch of undergraduate students who were asking amazing questions about lung cancer and how we can promote lung cancer screening. And I left so just enthusiastic about the future generation and just how altruistic they are and maybe the difference we can make together. So, yes, love that organization.
And Dr. Yang, but for those who don't know, he's a surgeon at Mass General, where I was treated, and but it's basically a force of like college kids who are just out there like making a difference to
Yeah,
raise awareness about lung cancer screening, which I think is just fantastic. It really is. So,
yeah.
so I just want to tell us about your passion for integrative medicine and how that makes a difference for patients. And I know we've talked about sort of quality of life, mind and body and soul, those conversations that you're having with your patients. And I know that places like MD Anderson have great supportive services, and Mass General is the same thing. But tell us about how do you kind of integrate that into your conversations with your patients and the
Yeah, we
caregivers?
talk about it. Absolutely. Yeah, we talk about it from the very start with almost all of my patients. I continue to say this mind, body, soul connection. I'm here to really help focus on the body, right? I can provide all the evidence from phase 3 clinical trials about why we're choosing this treatment, why it's going to work specifically for your cancer, how it's going to affect your body with regards to adverse events that may potentially, develop during the course of your treatment. But we also need to focus on mind and soul. And I need patient partnership with that. I need the partnership of their loved ones and caregivers as well. And so I'm a big believer that going in with a positive mindset, really paying attention to your mental health during cancer care is just as important as what we're doing physically to your body and just as important as the results of your scans. So I continue to stress that. And we have some incredible partnership at MD Anderson with our multidisciplinary colleagues in supportive care is one. Supportive care, for those of you who may not have heard that concept, it's also called palliative care. And there tends to be a lot of stigma when people hear palliative care.
Totally. I was just gonna say that.
Yeah.
Yep.
And they think palliative care means hospice. And we
Like end of
really
life. Right.
right. End of life. And it does not always mean that. There's this spectrum of support that palliative care physicians, supportive care physicians can offer. And the way I frame it to patients is I say, these are physicians who have had dedicated training in just symptom management. They're your symptom management experts. How can I provide you the best care if we don't pull in the experts who can help with symptoms, right? That's what they're trained to do. And when I frame it that way, a lot of my patients and their loved ones get excited. They're like, yeah, let's tag them in. And then add on the data that we've seen that was, came out of Mass Gen, right, several years ago that showed that patients that have early intervention with palliative care and early referral to palliative care and have lung cancer, they not only have a better quality of life, they actually live longer than patients that have a delayed referral to palliative care. So that's just exceptional to make sure that we include and we talk about when we're seeing our patients. So love, love, love the palliative care group.
I do too. And my friend Narges Flores, who I'm sure you know,
Yeah.
she talks about that all the time about how she wants to know the entire person because it's not just the 25 minutes that you're seeing a patient in the office. They've got a whole other life that's going on. They've got childcare things. Maybe they have mental health issues. There are all kinds of depression. There's all kinds of things and I agree with you about palliative care, by the way. That's why I was going to bring it up because
Yeah.
I think there is a stigma to that because people don't understand what it really truly means. And by the way, I know my treatment was a long time ago, but I had a little bit of invasive lobectomy and I had pain that was miserable for months.
Oh,
and I was not referred. Finally, I got referred to the pain clinic. I didn't even know there was such a thing as a pain clinic, but
yeah,
there was a gap. I think there was this gap of like not understanding that that was really affecting my. I was only 35 when I was diagnosed, so it was affecting my quality of life. I couldn't play basketball. I couldn't do the things that I had little kids. I couldn't
yeah,
hold them. It was just, you know what I mean?
yeah.
And so that's why it's so important to like have that compassion and really, and I use the word empathy because I
Mhm.
feel like we all need to be empathetic. Put yourself in the shoes of the other person,
Yeah,
right? Or
absolutely.
it's your mother or your grandmother or your sister or your brother. Like, how would you want them to be treated? And I think you have that kind of focus that I really appreciate.
Oh no, I appreciate that, and you're touching on, I think, really important topics here. I think making sure not only just palliative care, but there is definitely a pain clinic, and so at MD Anderson we have a pain clinic that's dedicated to helping cancer-related pain, and so asking about that is important. Integrative medicine, we actually have an integrative medicine clinic which uses evidence-based information to provide some additional alternative ways to help the mind, body, and soul throughout cancer treatment, whether it's acupuncture, massages, any other ideas that are evidence based. I think it's really important to see if your institution or the center where you're being treated offers opportunities like that.
Hmm.
And then I'll also say psychiatry and mental health is just as important as well. There's a lot of stigma surrounded around mental health, but we work a lot with our psychiatry team here at MD Anderson to make sure that patients are having routine mental health check-ins. I think that's so, so important as well.
And I think it kind of reminds me that I feel like when I talk to oncologists, you know, not just at the major places, the academic centers like MD Anderson or Mass General or Dana-Farber, but it might be a more community focused, and they just don't have this infrastructure or the resources that you have at a place, you know, like MD Anderson. And I think you told me that a lot of your patients aren't even from the Houston area. They come from all over the world, probably, right?
That's correct. Yeah, I would say that probably half of my patients, if not more, are actually not from Houston, and several of them not from Texas, and like you said, several that come from international locations. And so, it's a really unique place to be able to provide care. I'm so grateful for this opportunity. But it's definitely very unique, and it's a very special place, and we're very hyper focused on cancer. Obviously, that's our
Yeah.
mission, and it's a really unique place to be able to deliver care.
But I think, and I often say that everybody deserves the level of care that I received at Mass General, right?
Yeah.
Whether you live in North Carolina, you could like. There's a lot of rural parts of North Carolina. I did a project recently, talking with some oncologists around the state, not just at UNC and Duke, and but in like Elizabeth, I think, or like what was the other one? Jacksonville is a town called
Oh,
Jacksonville, North Carolina.
huh.
So I talked with a bunch of oncologists, and it's just like they just don't have the resources, or they might just they're general oncologists like Mass General or MD Anderson. You guys have a whole team of thoracic, right? And that's not the case. But I think everybody deserves that, and so
Yeah.
it's just my way of. I'm trying to like help any way that I can to try to raise that awareness that every patient deserves the care that you're getting, that I got, and the care that you give. And I'm not saying that they don't give good care, but they might be a general oncologist who only sees a handful of lung cancer patients every year.
Yeah, I think you also touched on a really good point here, Dave. The majority of patients with cancer receive their care out in the community. And so they really are doing a lot of heavy lifting. And I have so much admiration and so much respect for general community oncologists
Me
because they'll
too.
go seeing a patient with breast cancer to lung cancer to lymphoma, leukemia, and then add on other blood disorders as well, too, like blood clots. It's a lot. And it's really hard to keep up with all of the advancements that are happening. I am so hyper focused on lung cancer that now, only 3 years out of my fellowship and training, I am starting to not pick up on all the advancements on breast cancer and lymphoma and leukemia. So how are they doing it? It's a really, really hard job. But I agree. I think there's a way for academicians, patient advocacy groups to help community oncologists to raise awareness,
Yes.
right?
In fact, speaking of North Carolina, what's her doctor? I think her name is Patel.
Hmm.
She's at UNC. Do you know that name?
I don't
They
know.
have a service that helps run where they do second opinions and they help with they
Wow.
with satellite
Yeah.
places like UNC has satellite locations around the state,
Oh,
and
wow.
so she offers that. So I think those are the kinds of things that I can really be super impactful again because I have super respect for community oncologists as well, but
Yeah.
like there's no way that anybody could possibly keep up with all the advancements across all these different tumor types, you know?
Yeah. And then I
So,
actually posted just recently on social media about this concept of time toxicity. I don't know if you saw the recent publication that came out last month, and it was in JCO Practice Oncology. And what they showed was this study in Denmark where there was 4,300 patients with stage 4 lung cancer. And they just looked to see what the impact of time toxicity was for patients that were getting cancer treatment. So time toxicity just means the physical amount of time that patients are spending with the healthcare system, whether it's doctor's visits, labs, scans, infusion appointments, or even picking up medications, right? How much of an impact is it making? And what they found in this study in Denmark was first the 1 year overall survival rate for these patients with stage 4 lung cancer was 45%. It was just under half of the patients still being alive after 1 year of starting treatment. So that was something to think about. And then the second thing that they saw was that the median number of days that these patients were spending during their time alive, it was 56 days, which is like 1 in 5 days, a little bit more than 1 in 5 days of days being alive, where they were dedicated to having to physically go to the healthcare system to do whatever they needed to do for cancer care. And it's startling because we don't talk about this a lot. We talk a lot about the medical bills and the costs related to cancer care. We don't talk about the cost of time, what it means to pull patients away from their routine, their daily lives, and being able to pick up their kids from soccer games, right? And do all these things. It has such an impact. And so when we're talking a lot about community practice and having oncologists out in the community make a difference for their patients, I totally understand why a lot of patients have to remain within their local community, right? Because of this concept of time toxicity. But there's definitely ways to solve it. I think telemedicine, like you were referring to, these virtual sort of consults could be really helpful. And then just scheduling, optimizing schedules for patients is just huge. So things I'm thinking about constantly.
yeah, I'm thinking about it constantly too. I was recently on an ad board and there was a comment made about, well, every patient will do whatever it takes to. That's not true.
Yeah.
I'm sorry, but maybe I feel that way or maybe she feels this way, but I have a friend who chose to not go to continue his care because he didn't want to travel
Yeah.
to go to Detroit for this trial.
Yeah.
And so I think we just have to, again, being respectful of everybody's different. Everybody's different. And we have to be empathetic to the needs of and not just the patient, but the care partners too.
Yeah.
I mean,
No,
there's a lot of time invested. I mean, think about what that's like, you know. So I'm glad that you're
yeah.
thinking about this. That's really important. So
Yeah, no, I appreciate that. I think focusing on ways to provide equitable care for all patients with cancer, particularly lung cancer, is so important. And so you also touched just now on an important concept and topic, and that's how do we sort of remove these barriers to clinical trial enrollment? A lot of clinical trials have so much strict criteria, one, to enroll. And then second, once you're on, there's a lot of visits. Many of them have to be in person with the PI or co-PIs on the study at that location. How can we use telehealth? How can we use mobile phlebotomy? All these different ways to try and reduce these barriers and give patients back some time. I think it's really important to invest in.
yeah, and I'm actually on a couple steering committees, and we had this conversation about what you just touched on. You know, I think it really is this trying to make it more personalized, right? Like with not what's the word clinical trials that are like, or you might get your medicine at home, or you might have a visit from a nurse to your house.
Yeah.
Decentralized clinical trials. You know, so I think we're making progress, but I think you're right. I've seen, unfortunately, companies that say they want to get more diverse patients into a clinical trial like Hispanic or Latino, but they don't even have clinical trials in Texas. So it's like, well, so why do you have a clinical trial in like North Dakota? Like, you know what I mean? So it's like we're all in this together. You know what I mean? We all have to be thoughtful about how this works, right?
Absolutely. Absolutely.
Yeah. So I read that you, and I'm not sure if you still are, but you were an MD Anderson community ambassador for lung cancer.
Mhm.
That sounds really cool. So tell me about that.
Yeah, so MD Anderson is really focused, I'm sure, like other institutions, on getting out into the community and raising awareness and really helping patients understand one, who can get lung cancer, what the risk factors are, and then second, if you were to come with a diagnosis of lung cancer, there are opportunities for clinical trials. And so I spend a lot of time with regards to community outreach, working with the MD Anderson Ambassadors sort of program and community outreach programs to
Nice.
awareness about lung cancer. That's incredibly meaningful to me. And so at MD Anderson, I actually practice not only at the downtown medical center campus, but I also go about 30 miles away to the Katy location, which is in West Houston. And it offers an opportunity for patients that are out in that community or closer to San Antonio, Austin, other rural areas, even
I
to
love
be
that.
able to visit an expert in thoracic oncology. And so, very fortunate to be able to do that. And that's a really meaningful part of my practice.
I love that. That's awesome. So, am I going to see you at TTLC this year?
Yes, yeah, the new location.
New location. Hopefully the fires will be. I'm
I
worried about.
know.
I'm really. It's so. I just saw some videos of. It's just so sad.
Yeah,
So, but that's the targeted therapies for lung cancer conference. So, I look forward to seeing you there. So,
absolutely.
okay. So we could go on and on because I love talking with you. You're such a nice guy. But the last thing I want to ask you is outside of work, tell us something that you're passionate about or that people may not know about you.
Oh, okay. Well, you're putting me on the spot, Dave. Let me think. I love traveling. I love getting to meet new people. I feel like lately work travel has become a lot of sort of my main travel, if you will. And I've been grateful to make a lot of friends in the lung cancer community, patient advocates and dear friends and colleagues as well, right? Getting to see everyone and connect is so much fun. But I feel like a lot of people know that about me. So let me think of something different. Lately, I've really started to engage more in social media that's patient facing. Initially, I was using social media for educating myself, educating colleagues about all the latest advancements in lung cancer. And so going more to that patient facing sort of social media aspect to empower patients and educate patients, I wanted to think of different ways to engage them and have fun while educating. And so lately, I've picked up a lot of dancing, which has been a lot of fun. And so TikTok trends for dancing and Instagram reels for
Wait, are
dancing.
you dancing? You're doing the dance? You're dancing?
Yeah, yeah, I've been learning these dances,
Okay.
uh,
Oh, on
which is
TikTok. I'm gonna have to go
yeah,
find you on TikTok. I'm gonna have to
yeah,
find
yeah,
you.
yeah. You can find me, and it's been a lot of fun. And actually, I used to. Maybe people don't know this about me, but when I was younger, high school and in college, I used to do Indian dance. So I used to do Bhangra and Bollywood type dance, and so that kind of took a backseat for quite a while when I went through medical training. And it's fun now to kind of reconnect and think of other fun ways to engage and educate and bring
I
back.
love it. I love it. In fact, it reminds me, you know, Dr. Agarwal from Penn?
Yes, absolutely.
I came across her because I saw her on social media dancing with her husband
Oh
back
wow.
during COVID. Like
Oh
it was
wow.
so funny. It was so entertaining. And I said, I got to meet this woman because first of all, she's at Penn, which is my alma mater,
Uh,
but she just seemed so fun and I think her husband's a doctor as well. But
yeah.
anyway,
She's an incredible human, and
she
speaking
is.
of sponsors, she's been an incredible sponsor for me as well. And I need to go find that video now, and then maybe me and her can do a collaboration. We can dance together.
Count me out. Sorry, I'm not. I'm not. I don't think I'm ready for that. But
We'll
anyway,
continue. Yeah, we got you.
you got me. You got me. Well, anyway, thank Eric. Thank you so much. It's been a wonderful conversation. Thank you so much for what you do for the lung cancer community. And it's an honor for me to have met you in person recently and call you my friend. And thank you for being on the show.
Right back at you, Dave. Thank you again for inviting me and for this very honest, candid, and transparent conversation. I appreciate it.
Awesome. Thanks.